Hi everybody, you are listening to the Medea podcast series. Medea Medical Education Academy is a global medical education provider dedicated to designing, delivering and evaluating medical education programs worldwide. Today we are going to speak with Nemencio Nicodemus Jr., Professor at the Department of Biochemistry and Molecular Biology of the University of the Philippines College of Medicine, and Clinical Professor at the Division of Endocrinology, Diabetes and Metabolism of the Philippine General Hospital in Manila, Philippines. Professor Nicodemus will be chairing the upcoming Medea Live webinar on hyperglycemia in pregnancy and beyond on October 18, 2024. This podcast is part of the continuing medical education program entitled Blended Learning Journey on Diabetes and Prediabetes, targeting clinicians involved in endocrinology, particularly diabetes, prediabetes, fertility and pregnancy management, obesity management and general practice, midwives and nurses involved in prenatal and postnatal care.
Good day, everyone. I'm Professor Nemencio Nicodemus Jr. I am an internist endocrinologist practicing here in the Philippines, and I'm a professor at the University of the Philippines College of Medicine. I would like to welcome you to this podcast about hyperglycemia in pregnancy and beyond. In this particular podcast, we will be able to understand how to screen for hyperglycemia and diagnose gestational diabetes. We will competently manage diabetes in pregnancy and plan and deliver the postpartum screening programs for such kinds of patients.
What measures are in place to help those who have or who are at risk of type 2 diabetes who are planning a pregnancy?
The good thing is that there are several guideline-giving bodies, the American Diabetes Association, even the European Association for the Study of Diabetes, and our colleagues, the obstetrician and gynecologists, have come up with guidelines on how we should be screening patients who are at risk of developing hyperglycemia in pregnancy. Of course, this begins with screening for the risk factors that are available. And these risk factors include, of course, the presence of obesity, the presence of family history of diabetes, the presence of previous pregnancies which have large babies, and the presence of polycystic ovary syndrome. These are states which are insulin resistant and therefore will make a woman develop hyperglycemia even during pregnancy. And so these measures are available for us so that we can screen early women who might develop hyperglycemia in pregnancy.
The incidence of type 2 diabetes is increasing generally in the population and is becoming more prevalent in younger individuals. In this scenario, is enough being done to identify those with hyperglycemia in early pregnancy?
I think we should be increasing the way that we screen for hyperglycemia in pregnancy, starting even before pregnancy. We know that women may actually have hyperglycemia without any symptoms. And therefore, if we start screening women when they are pregnant, then it is highly likely that we will be able to miss out on women who might have developed hyperglycemia earlier on during their pregnancy. And since the current recommendations is to start screening during the second trimester of pregnancy, an earlier screening would definitely benefit the pregnancy in terms of outcomes for both the mother and the fetus.
What are the core strategies to help those with hyperglycemia during pregnancy?
There are several strategies that we employ, and of course, these may be very unique to the woman who is pregnant, and some may be general in terms of people with hyperglycemia in general. Important measures that we do are, of course, more frequent blood glucose monitoring, such that we are able to maintain the blood glucose within a critical range that will be beneficial for both the mother and the growing baby. We should also address hypoglycemia, which is also a very real problem for women who are pregnant, especially during the first trimester. Another issue that is very unique to women who are pregnant are, of course, the medications. We know that there are certain medications that may not be applicable to women who are pregnant, and therefore, we should adjust these medications accordingly, and we should use those that are based on evidence. Very crucial to hyperglycemia in pregnancy is really meal planning. And so the meal plan that might be recommended for a woman who's not pregnant may not necessarily be the same for a woman who's pregnant. And therefore, these should be taken into consideration. And very important for us is that during pregnancy itself, there are a lot more unique features such as more frequent healthcare visits that might need to be done. Of course, a multidisciplinary care, which will involve not just the OB-gynecologist, the endocrinologist, the nutritionist, dietitians, and even perhaps our perinatal colleagues who are able to monitor the growth of the baby. And needless to say, all of these can cause anxiety on the part of the pregnant woman. And therefore, psychological stress management is also very important all throughout the pregnancy among women who develop hyperglycemia in pregnancy. And we don't stop during pregnancy. The thing is, after pregnancy, once they have delivered the baby, it is important that they're also able to monitor their blood glucose status and even the outcomes of pregnancy.
Ideally, postpartum, what measures should be in place for the long-term health and well-being of both mother and baby?
Well, as I have mentioned previously, we start with, of course, the pregnancy. But during the postpartum, it is crucial that we monitor the mother's blood sugar because if this is gestational diabetes, the blood glucose can actually drop immediately after the delivery of the placenta. But for women who might have pre-existing diabetes prior to the pregnancy, their blood glucose may continue to be elevated. And therefore, crucial within the first 24 to 48 hours is really the blood glucose monitoring of the woman or the woman who has just delivered her baby. This will further on be continued at the earliest could be to ask the woman to have an oral glucose tolerance test at least 6 weeks after pregnancy, by which time we expect the hormonal changes that happen during pregnancy to have already stabilized, and such that we could do a formal oral glucose tolerance testing to assess the glycemic status of the woman, whether she has returned to a euglycemic state or whether she has persisted to have impaired glucose or even developed overt type 2 diabetes. This is also very crucial because during the postpartum period, if the mother had uncontrolled blood glucose during pregnancy, it will also have an impact on the blood glucose of the baby. We know that uncontrolled blood glucose during pregnancy will lead to hyperinsulinemia in the fetus, and upon delivery, when the umbilical cord has already been cut and the baby hasn't had any nutrition yet, that baby could develop hypoglycemia and have severe consequences as a result thereof. And so really monitoring is very crucial, but more important than that, blood glucose control is very important, especially during the pregnancy period.
How is metformin used during pregnancy changing birth outcomes and long-term health of both mother and child?
We all know that in the past, we were limited with just very few interventions that we could safely give among our pregnant patients with hyperglycemia. Of course, aside from nutritional therapy, which is still the cornerstone in the management of hyperglycemia, we only had insulin in the past. And in fact, the human recombinant insulin used to be the standard of care. But with newer generation insulins, we have added other insulins that are long-acting to our armamentarium. But the question often arises, can we safely use oral anti-diabetes drugs to control hyperglycemia in pregnancy? And we know that among the different drugs that we have in the market, metformin has been one that has been present for the longest. Good for us. There are newer studies that have actually studied the use of metformin among women with hyperglycemia during pregnancy. And although the initial studies tell us mixed results, that perhaps there could be an increased risk of premature delivery, with the newer studies, particularly the randomized controlled trials, using metformin among patients With gestational diabetes, we know that the data shows us better results, that perhaps these oral agents can be used safely among our women with hyperglycemia in pregnancy, and that adverse perinatal outcomes and adverse maternal outcomes seem not to be increased in these women. Of course, these preliminary studies are very reassuring, and with time, with more studies, we will be able to say whether metformin can really be part of our standard of care for women who have hyperglycemia in pregnancy.
What are the risk factors in developing hyperglycemia or diabetes in pregnant women?
The risk factors among women who do develop hyperglycemia in pregnancy or even overt diabetes during pregnancy, of course, very important is family history. But aside from family history, a very important risk factor would be the development of obesity. And aside from obesity, however, several other conditions that may be present in the woman, such as a polycystic ovary syndrome, which increases the risk of insulin resistance or is characterized rather by insulin resistance, is really a risk factor for future development of hyperglycemia. Of course, we know that certain other laboratory parameters such as impaired fasting glucose or impaired glucose tolerance prior to pregnancy really increases the risk of hyperglycemia during pregnancy. And so these risk factors must be identified in women as early as possible so that we could identify those women at high risk of developing hyperglycemia during pregnancy.
What take-home messages do we have at the end of this podcast?
The take-home message for this podcast is that it's important for us to identify women who are at high risk of developing hyperglycemia in pregnancy, and this starts with looking at risk factors prior to pregnancy. That's one. Number two, it is important that we control hyperglycemia during pregnancy, and this will impact the maternal outcomes and the perinatal outcomes that will ensue afterwards. And number three, we just don't stop with treating the woman and the baby during pregnancy, but postpartum follow-up will be very important for long-term advantages and, of course, looking at the long-term effects of hyperglycemia on both the mother and the fetus. And at this point, I'd like to welcome everyone and I'd like to invite you to attend our webinar on hyperglycemia in pregnancy and beyond. And this will happen on the 18th of October, 1 to 2 p.m. Central Eastern Europe time.
For more information about our upcoming webinar, Hyperglycemia in Pregnancy and Beyond, which will take place on October 18th, 2024, please visit our website at medeaacademy.com.